Well, good afternoon, ladies and gentlemen. We have with us over here Dr. T de Villiers, and we're going to always be enthralled by his talk, which is menopause hormonal therapy in 2025. Thank you very much indeed, Toby. You've been very generous with your time in the past, and we look forward greatly to having you again on the subject of menopausal hormone therapy in 2025, which is sponsored by Abbott this time. My name is Peter de Jong, and our co-host is Professor Stephen Jeffrey of the Pelvic Floor Foundation. It's wonderful to have you, Steve.
Thanks, Pete.
And
wonderful to have you too.
Thanks very much. Just before we begin, we're going to have a very short video presented by Abbott. And I'd like to remind you all that in 5 months' time here in Cape Town, CTIC.
I know what it is.
What?
I think it's SASOG.
No, Steve, you got it wrong again. You weren't paying attention. It's the FIGO World Congress, their 49th World Congress. It's here in Cape Town, right next door, and I urge you all to attend. Toby is, in fact, the session chairman in menopause, so we look forward to that as well, Toby. So, ladies and gentlemen, without further waste of time, I'm going to call upon Abbott to show their video. It's wonderful to have so many people logged on, well over 100, and I have no doubt we're going to have a lovely afternoon this afternoon with T de Villiers. Abbott and the video. Thanks, Chris. Thanks, Chris. And a thank you to Chris as well.
June had always led an active life, but when she reached menopause, her symptoms caused her to feel isolated, affecting her work and home life. Medical societies recommend menopausal hormone therapy as effective or the most effective treatment for menopause symptoms. But not all MHTs are the same. In women taking estradiol and dydrogesterone, the ingredients found exclusively in Femiston, there is a lower risk of breast cancer compared with other combined MHT. And the risk of venous thromboembolism is lower than in users of other oral preparations, such as norpregnane-type progestogens, or no MHT. With proven benefits for a range of menopausal symptoms, Femiston can help June take back control of her life. Femiston makes her life better in post-menopause. Femiston is the world's #1 brand for estrogen deficiency in volume.
Great. Well, thanks for that video.
Thanks, Chris. If we could ask Toby to share his slides, please. There we go.
Thank you, Peter and Stephen, for the kind introduction, and thank you to our sponsors, Abbott. We just have to put this disclaimer on Abbott, but it basically just says that the opinions expressed here are my opinions and not necessarily their opinions. And I also have to disclose that I have done talks for virtually everyone in the menopausal hormone field. Now, what we're talking about today must first be defined, and that is where exactly does the menopause fit in? So in the middle of your slides, Peter, can you just confirm if I put the pointer, can you see the pointer on your screen or not?
No, we can.
Okay. We do now. Thank you.
Okay, so that the pointer is now here on the final menstrual period. So the final menstrual period is actually the menopause, but we cannot define that until 12 months have passed after the last period without any bleeding at all. So it is preceded by the menopausal transition, also called the perimenopause. And this is a hotly debated or hotly discussed, especially on social media, a period of a woman's life. And that starts as early as in the 40s and or the early 40s, and it has an early onset, which is variable, but mostly characterized by menstrual periods being 7 day longer on a consistent way than they were before. And in the late phase of the perimenopause, we will have intervals of amenorrhea, no periods of more than 60 days. But it's only really, so the perimenopause stretches from the menstrual cycles that start becoming funny till 1 year after the last menstrual period. The postmenopausal time stretches really from the last menstrual period till the day a woman dies. Now, what about the hormonal changes that we find here? It is interesting that the perimenopause, and the reason why it's so difficult to really pin this down in terms of treatment excessive, is that although we have on the whole a lowering of estrogen levels, it is not a constant low, but there's a pattern of variation in ups and downs that we find in this time. And that's really what amounts for the sort of roller coaster of emotions that women can have. In terms of biochemistry, I want to make it quite clear that we don't actually need any tests to define menopause. If it fits in this period of time between the age group of 45 and 55 with the suitable menstrual periods, you don't need a blood test to show you what is going on. So in this period, and especially then after the last menstrual period, there can be various effects on the body, and that all of them are important to us, but the most common one will always be the vasomotor symptoms, and the other ones we will, or all of them, discuss now. It is easy to remember that the symptoms basically can be categorized into the early menopausal symptoms, which are basically the vasomotor symptoms, the late menstruation symptoms, which are the bone effects, the brain effect, and the heart effects, with sort of the in-between one, the one that you guys are interested in, the urogenital atrophy. It is also then important to note that especially the vasomotor symptoms, the sleep disorders, and the mood changes can start earlier than the last menstrual period. Whether it's so easy to treat them is a different story. Well, there's always a debate about everything. And what's the debate about the menopausal hormone therapy at the moment? It's not really anything new, but it was again brought to the fore in a Lancet, and you have to listen when the Lancet speaks, and where they've said that although menopause is a natural phase of life, it's being over-medicalized, framing menopause as a disease of estrogen deficiency that can only be used by menopausal hormone therapy. So the International Menopause Society replied to that and completely denies this allegation, but it agrees that all women should be counseled and have access to the full armamentarium of treatment, including menopausal hormone therapy and non-hormonal options. So we say it's not a one-size-fits-all, and that they're not really right in making that allegation. The Menopause Society, or the previous NAMS, the Americans, they keep on changing their name. They now reckon they are the Menopause Society. They just made a strong point that whatever people say, the menopause and associated symptoms has a huge impact on the workforce at an annual cost of about $1.8 billion in the USA, calculated on missed work days. So whatever the Lancet says, if anybody says, this is a problem, especially in the workplace. So if we have to generalize, then let's have a look at the main benefits and risks. The main benefit still remains suppression of vasomotor symptoms or hot flushes, the treatment of GSM, the genitourinary syndrome of menopause, which you guys specialize in, but also the prevention of bone loss and fracture protection. But very important as well, improved quality of life. The risks are really becoming smaller and smaller. The VTE risk we can manage, and the breast cancer risk we do not recognize at that it will cause breast cancer, but there can be a promotion of already present breast cancer. So if we then have a look at the vasomotor symptoms, this was a recent article that I'd written on the subject, and I came to the conclusion after again reviewing all the literature that menopausal hormone therapy remains the first choice for the treatment of menopause-related vasomotor symptoms. So to just in short explain how the estrogen deficiency causes these symptoms, if you have a look at the bottom line here, in a premenopausal woman, the core body temperature will only be protected if it goes very high, and that would then cause a hot flush, or if it goes very low, and that would cause shivering. But as the estrogen diminishes, this thermoregulatory zone becomes very narrow. And now, with the core body temperature just slightly above that, it will cause a flush, or slightly below that, it will cause shivering. So it's all about the lack of estrogen and the way in which it affects the hypothalamus and associated structures. And more about that a little bit later. So the vasomotor symptoms, also called the hot flushes, are the hallmark symptom of menopause. It will affect the majority of menopausal women, but the severity may range between mild, where it doesn't really affect the quality of life, moderate or severe, where it severely affects quality of life. It may start in the perimenopause or in the postmenopausal period. We used to say that it may last from 5 to 8 years, but we now know that for some it will never disappear. In affected women, it's a cause of distress with lowering in quality of life. Vasomotor symptoms in itself is not just an uncomfortable symptom, but it's also a marker for other effects, such as a negative effect in the cardiovascular system. So the effective treatment of vasomotor symptoms is thus more important than just the symptomatic relief. So what is the treatment for vasomotor symptoms? Then menopausal hormone therapy, whether estrogen alone or opposed, consistently reduces the frequency and intensity of vasomotor symptoms in a dose-related response in a significantly superior way compared to placebo or non-hormonal options. The examples that I'm using are the examples of the drugs of our sponsor. I just think it's fair, but we could have used any of these ones in terms of menopausal hormone therapy. And here we have a look at the ethinyl estradiol 1 milligram opposed by 5 milligrams of dydrogesterone, and you can quite clearly see that compared to placebo, it virtually eliminates the hot flushes. Now, it is important just to note that there's always a very strong placebo effect. If there's not a strong placebo effect, it's not a good study. And it's not really a placebo effect, but just an indication that the ovaries can, without causing menstruation for quite a period of time, have intermittent levels of estrone or estradiol in the system, which is then actually causing the placebo effect. This is also for the 110 combination, 1 milligrams of E2 with 10 milligrams of dihydro. And in this study, you can also see that it is highly effective. Now, what are the other symptoms that can be treated by menopausal hormone therapy? So there are 4 clusters of symptoms, all associated with vasomotor symptoms. It can be psychological, and you can go through the list there. It can be somatic, it can be vasomotor, or it can be sexual discomfort. Now, all of these clusters do respond to menopausal hormone therapy. So what about the urogenital changes and sexual dysfunction? I'm not going to go into this in great detail because you guys know a lot about it, but the changes in the urogenital tissue during and after menopause can lead to discomfort. It can lead to dyspain during intercourse. It can also be associated with stress incontinence and then in total with sexual dysfunction. Now, the treatment of the VVA, that's what I still like to call it, vulvovaginal atrophy, although the Americans convinced everybody that it is not a good idea to have the word vagina into such a symptom. So they call it genitourinary syndrome of menopause. Doesn't really matter. But the first one would be the lubricants and moisturizers. Menopausal hormone therapy actually then remains the gold standard of treatment. And this can be either systemic or local or combined. So just remember the local therapy will probably always work better. But if you have a patient on systemic therapy that has symptoms as well as VVA, about 20%, and some people even believe it's more, will still need local estrogen therapy in combination with the systemic therapy. In South Africa, we haven't got the selective estrogen receptor modulator, ospemifene. I published quite on it, but it works well, and it should work because it is an estrogen receptor stimulator in the vagina. In the USA, we also have vaginal dehydroepiandrosterone, which is not available here. It also seems to work well on an intracranial principle. And then the question of vaginal laser therapy, I will address that in a moment's time. So in terms of the sequential estradiol dihydrogesterone, this is just a snapshot of what this can do. In this slide here, I put a bar around the vaginal dryness. You can see how much it improved on that, but it's also for comfort during intercourse. Okay, so what about the laser? I see Stephen giving a frown there, but laser is used for different purposes in the pelvic floor medication. I'm only talking about treatment for the genitourinary syndrome of menopause. So the one that I like very much is I was a judge at the IMS World Congress, and this was the winning presentation there. So this lady had 60 women with moderate to severe GSM symptoms, and they were randomized to laser or sham treatment. In other words, they still went to the machine. The machine had all the lights on and that, but it was not effective. There was no treatment given. And the outcomes basically assessed at 12 weeks and 18 months showed virtually no effectiveness of the laser therapy. And this was, again, reiterated or found in a study by Jason Abbott. That's not the company, an Australian, which basically came to the same conclusions in a much larger study. So I don't think that there's at the moment very good evidence that it actually works for GSM, and that it is probably better just to use estrogen systemic or local. What about bones? Now, we know that the bone mineral density in women undergoes a very quick bone loss at the menopausal transition, and that can be measured in terms of bone mineral density. It can also be measured in terms of the trabecular bone score, which shows quite a decrease in the bone quality associated with the menopause. And we learned from Swan that accelerated bone loss occurs actually from 1 to 2 years before the final menstrual period till 3 to 4 years after the menstrual period at both the spine and the femur neck, and that bone loss is maximal in the period 1 year before menopause and for the subsequent 2 years. So the cumulative bone loss during this time can be up to 10% at the spine and 9% at the femur neck, mounting to a lowering of about 1 standard deviation, 1 T-score unit. So I'm just putting this up here to show you that there is massive bone loss associated at the menopause. We unfortunately are not yet able to identify the patients that will be the fast bone losers, but we are doing at the moment looking at the patients from the Swan study. The Swan study, these studies are averages of the whole groups, but looking at individual patients with bone loss to see if we can find anything. Now, what is the point about doing this? The point is that we have effective drugs, of which menopausal hormone therapy is the most effective, to prevent that bone loss. So we're not talking about the treatment of osteoporosis. We are talking about the prevention of menopause-associated bone loss. And in this aspect, the difamostin with the E21 milligram and works very well in maintaining the bone loss. Now, and you can see on the slide there yourself. But it's important to know that we also have evidence from the WHI study that menopausal hormone therapy, but in that case, the not 17-beta estradiol, but equine conjugated equine estrogen at the higher than standard dosages. At that stage, it was normal to do a 1.25 milligrams for the patients. But combined with or without medroxyprogesterone in the WHI trial also showed fracture reduction on all aspects, and the patients weren't at particular risk of osteoporosis. So that is the only drug and the only place where we actually have fracture figures, except for tibolone, which also showed that in a prospective randomized study. So in terms of the sponsor's product, we have evidence for the prevention of bone loss, but we do not yet have evidence for fracture protection, although there's no reason to believe that it will not take place. So what then are the indications? We said VMS improves the quality of life. It's effective in the treatment of GSM, prevents bone loss and fractures in one study. But it also has mild effects against menopause-induced anxiety and depressive symptoms. But we do not use this specifically to treat those symptoms. If it is significant symptoms, it must still be treated by conventional antidepressant and anti-anxiety drugs, but it will not make it worse. So what other potential benefits are there? Well, reduced mortality. And I will show you that I don't think actually it's potential. I think it's true. Reduced cardiovascular disease, which is a slightly more complicated subject. We know that it reduces colorectal carcinoma in virtually all the studies, that it improves glucose tolerance. I'm always quite surprised to find that especially physicians think that it will be bad for a patient with, for instance, diabetes 1 or 2. In fact, it works very well in them. Then we generally believe that it has an improved effect on dementia, but that is again a more not a very, we cannot say that with all certainty, and I'll show you here that the potential adverse effects could then be increased risk of cardiovascular disease, myocardial, and stroke. But that is, at the moment, we believe, if started outside the window of opportunity, that's started before 60 or after 60 and after 10 years from menopause, higher than normal dosages. And these days we all use low dosages, and then more perhaps with oral and long duration of treatment than with transdermal treatment. And increased risk of VTEs, that is only on oral administration at higher dosage, older age, or metabolically active progestins. So I will show you that in our sponsor's product, it is not true. There is not an increased risk when you use dydrogesterone. Now, there are people that believe that it can actually give an increased risk of dementia, and that was one Danish population-based study that did show an increase of dementia irrespective of when started. But that has not been shown in any of the other studies, so you always have to weigh up one study against 15 studies that could not prove it. So I don't think that it increases the risk of dementia. I believe that the favorable effect that it has on the vasculature of the brain actually will reduce the risk of dementia. But that's a very difficult thing to prove. As far as breast cancer is concerned, and that's probably the elephant in the room to most doctors and patients alike in prescribing menopausal hormone therapy. But I will show you just now on some slides that the risk is actually very, very small, even in WHI. The small increase in risk was one extra case per 1,000 women, with the combined therapy, and it was actually a smaller incidence in patients on estrogen alone. But there is an increased risk of gallstones, cholecystitis, and cholecystectomy, and that always should be kept in mind, and probably in those patients, oral therapy will be preferred. So what about gynecological cancers in general? So if we have a look at this nice study, it's one of the studies that was done on the data from the General Practice Registry in Britain. We can see that if we have a look at patients that used no MHT, that's in the light blue, the ones that used other forms of menopausal hormone therapy, and in the purple or magenta there, the patients that used the sponsor's product, which contained the dydrogesterone, we see that the risk of breast cancer, ovarian cancer, uterine cancer, and cervical cancer was actually the lowest in the patients that used the famostin-like products. Okay, so putting the breast cancer safety into perspective. So this refers to the incidence per 1,000 women that started menopausal hormone therapy age 50 to 59 over 10 years. Now, so if we say then that the incidence in this time, so when we put a time span, it is always incidence and not prevalence. So if we say that in women who are not using anything, there will be 23 cases of breast cancer. That's what you see at the top. So if you use combined hormone therapy, and that's now all types of therapy, we can have maximum 4 more cases. But if we use estrogen alone, we have 4 fewer cases. Compare that to an obese woman with a BMI of over 30, and you see that it fades into insignificant compared to an obese woman. But just having 2 or more units of alcohol per day gives an increase of 5 cases. The combined hormone contraceptives also give 4 cases, current smokers 3 more cases, and if you have a mild amount of exercise, it seems to be good for everything. It also reduces the risk. So what we see here is definitely not a causative effect, but it is a promotional effect. So it will promote the cancer in women who have the genetic mutation, whether acquired hereditary or whether acquired as a chance mutation. And why is it more on the combined cases? It will be more because the stimulation of estrogen receptors will be more and will be enhanced. And that is why over a period of time, like defined here, you will see more cases. So let's just have a look to see whether the effect of all the progestins used in combination therapy has the same effect. And this is very interesting data from the E3N, the French cohort study, where we see that when pure progesterone was added, there was absolutely no effect on breast cancer incidence. When dydrogesterone was added, there the second one in blue here, it was also non-significantly increased because it crosses the line of 1. Estrogen alone in this particular study actually showed a slight increase, but estrogen with other progesterones certainly had a different profile from estrogen with dydrogesterone. So the choice of progestin or a progesterone, the P4 natural one, certainly makes sense in these cases. Now, what's happened to the long-term follow-up of patients with breast cancer that were diagnosed in the WHI study? So they were followed up for roughly 20 years, so that's a long time. So the patients that used the CEE, that is the conjugated equine estrogen plus the MPA, so these are the ones that we were worried, the higher breast cancer incidence were sustained in the 20 years to about the same extent, but there was no difference in breast cancer mortality between that group and the patients that used nothing, that were on placebo. So it's very important that you can tell your patients, even on the worst form of combined therapy, that it certainly will not make them die. It will actually make them live the same life as anyone else. But if you can use your estrogen alone, there was not only a lowered breast cancer incidence that was sustained for the 20 years, but there was now also a lower breast cancer mortality. So that's very interesting figures that we got on these long-term follow-ups. So these are just a few other studies, again, to strengthen the belief that estrogen plus dydrogesterone is a good combination when it gets to breast cancer. And in this vast study, you can here see that there was no significant increase in breast cancer on the dydrogesterone-containing preparates, whereas when other forms of progestin like levonorgestrel or medroxyprogesterone acetate was used, we saw the higher incidence, the 4 more cases. So what are the major lessons that we learn from WHI? I think the first one is that all-cause mortality is not raised in patients on any form of menopausal hormone therapy. So this was the 18 years cumulative follow-up, and they're still following up these patients, where in the pooled group of all the patients, whatever form of hormone therapy they were on, it was exactly the same as the patients who used, compared to the patients who were on placebo, and slightly lowered in the patients on the CEE alone. That's for all-cause mortality. So that includes everything. In terms specifically of cardiovascular mortality, for the pool group, again, it was exactly the same as the placebo patients, namely 1. Total cancer mortality, the same, no statistical difference. But the interesting thing is that if we look at total mortality just in the age group that started between 50 and 59, we see that there was a marked reduction in the deaths, and in other words, a better mortality rate. So that's, again, very reassuring that you can tell your patient if they started whatever form before the age of 60 or within 10 years of menopause, that they have a lesser chance of dying from anything. So this again just puts it in perspective on a meta-analysis of 23 studies showing that in the younger woman it is favors treatment, but in the older patient there's no. In the patient started after 10 years, you did not see that reduction, but also there was no specific increase. And we will talk about that just now. So what are the risk of cardiovascular outcomes? Again, this is from the GP database in the UK. So if we again have the 3 colors, the light blues, no menopausal hormone therapy, the dark blues using our sponsor's product, and then in the magenta, in the magenta, the patients that are on our sponsor's product. These are the other forms of menopausal hormone therapy. And then just as in the cases of the mortality, which we had a graph just like this, now we can see that in terms of the medroxyprogesterone, there was no negative outcome. There was actually a better outcome than the patients that used nothing. So then if we have to weigh up the risks and benefit of menopausal hormone therapy, we'd also always say that if you started earlier in the window of opportunity, the risks are, or the favorable effects are more likely to outweigh the less favorable effects. So why is it like that? And that is because if you wait for 10 years, then there is the possibility that the arteriomatous plaque deposits in the coronary arteries have already got a significant impact. And if you then add estrogen to that, there will be destabilization of the plaque with an initial increase in cardiovascular events, only followed by a favorable event later on. But now, as anything in life, this whole question of the window of opportunity is being questioned by Susan Davis, which you probably all know as the testosterone queen of Melbourne and Australia. And she have given all the evidence, which was actually now again published in the Lancet. So it's been heavily peer reviewed if the Lancet accepts it, which actually shows, and that goes down to the one slide where I show you that although there was benefit on the estrogen alone, the effect on the combined therapy was virtually the same as the patients that were on placebo. So Susan wants everybody to go back to the figures to see whether it is in fact dangerous to start the patients after the age of 60. And she believes that too many patients are being denied the benefits of hormone therapy. Patients who have waited too long, but after 60, they find that they do have significant impact on their life from hot flushes. Patients who have osteoporosis but cannot use any other drugs, and whom it would be much easier just to do menopausal hormone therapy, that they are unjustly denied the effect to do that. The dangers are in fact very small in the time. So as always, there will be controversy, but in this case, the controversy is towards widening the indication for menopausal hormone therapy. We are running a little bit short of time, so I'm just going to, you all know that the effects of the progesterone and the dydrogesterone on DVTs and is much smaller than the other more potent progestins. And here again, we see that in our sponsor's product with dydrogesterone, there is not a significant, there is a slight increase, but it's not significant when compared to placebo. I'm not going to talk a lot about the contraindications to menopausal hormone therapy. I think you all know that. I think we can maybe just endometrial carcinoma. So after hysterectomy, estrogen alone is commonly given, but continuously opposed MHT is theoretically better. And the systemic hormone therapy is not advised with high-grade advanced stage endometrial cancers or with endometrial stromal sarcomas or leiomyosarcomas. So endometrial carcinoma is a very special category. And then in terms of ovarian cancer, it is not for all ovarian cancers, but we say that you should probably avoid it in the granulosa cell or low-grade serous carcinomas. With all the other ones, it has no effect. And also very importantly, malignant melanoma is not a contraindication to menopausal hormone therapy. So when should it be used? It is a personal decision taken by the woman and a healthcare provider based on the benefit to risk profile. And this is most likely to be favorable in the window of opportunity. Now, very important is that we say there's no mandatory rule to stop at any age. So we used to say stop at 60 or 65, but you actually are doing the patient a disfavor if you stop the hormone therapy just for the sake of stopping it. In terms of the progestogens, we have now time and again said that our pure progesterone and dihydroprogesterone, which is basically just a mirror image of progesterone, are probably the two progesterones of choice to take. And the reason for that is that they are the purest of stimulators of the progesterone receptor without having added estrogenic or anti-estrogenic effects or other metabolically active effects. And that's where the problem comes in. So there is good reason to believe that it is a better idea to use the progestin that has the least side effects. In terms of the sponsors' formulations, we can give the estrogen continuously with the progesterone just in the last 14 days. We don't stop. There are no placebo periods, but the patient will bleed at the end of the cycle. So if you want to use hormone therapy in the perimenopausal period, this will most probably be the best of those. And in the patient, who is already postmenopausal, you have 2 dosages of continuous combined ones, either 1 milligram with 5 milligrams or half a milligram with 2.5 milligrams of dihydro. So just remember that we only oppose it if the woman still has a uterus intact, which these days, with the few hysterectomies that we do, are the majority of patients presenting in menopause at the moment. So what about the route of administration? Yes, if you are worried about DVTs, then it's probably better to give it transdermal, but should only transdermal MHT be given? No. Patient preference, I think, is to be considered, because the best form of hormone therapy is the one that the patient will actually take. So if the patient will not do well on patches or creams, it is then better to give her oral therapy, if that's going to be. Now, we should then also just bear in mind that we've already shown that your dihydrogesterone containing preparates do not increase the risk of DVT, so that's fine, and is also very neutral on the breast. In certain conditions, transdermal would certainly be the first line. That's in hypertriglyceridemia, hepatobiliary disease, migraines with an aura. The age over 65, if you want to start it there, it'd probably be better. Established cardiovascular disease, a past history of VTE, or in the patient with diabetes. Opposed or unopposed? Always opposed if there's a uterus. If there's not a uterus, you don't oppose it, for the simple reason that all forms of progesterone will temper the effect of estrogen, especially on vasomotor symptoms. So if you can use estrogen alone, that is what you do. So the general principles are that the benefit is likely to outweigh possible adverse events in the window of opportunity. Estrogen alone, if possible. You always start with the lowest dose and rather titrate upwards, if necessary, till the lowest effective dosage. Now, don't follow the lines of the compounded hormone guys who will forever be doing blood tests on the patients. This is not a condition where we heavily depend on any blood test. This is a condition where we rely on the patient's clinical response. And if the patient responds on the lowest dosage, that is where you should end. And that should also be enough for bone. But if you're really primarily dealing with a bone condition, then the higher dosage would probably be best. And the most appropriate length of time will depend on the indication. In, for instance, bone, it is best to continue. And that brings us to the last really important new sort of study. That's the one by Bike, which was published in Menopause at the end of last year. So basically, this is a magnificent one of these big data studies where they have 10 million women on Medicaid in the United States, where they know exactly what they're taking because they get all their drugs from the company. They know whether they take it, in other words, whether they fulfill their drug, and they've got complete access to any codes that comes afterwards. So what they did here is they had a look at 3 groups of patients: patients who never used hormone therapy, compared to patients who used it till 65, compared to patients who used it forever. And to cut a long story short, the patients on estrogen alone did significantly better in all aspects, including the total morbidity, but also in terms of breast and in terms of dementia, etc. Now, the group that used the opposing progesterone, and this is an American group, so it's mostly MPA, did not have all those benefits, but they were not worse off than any of the other groups. So I think that this study, to me, is a very good study to show that you can actually continue and that there is no particular need to stop at any particular age, except if you have a very, very specific reason. So we do not, from the IMS and from the South African Menopause Society, we do not promote the prescription of the compounded hormone preparations. And the reason for that is just that everything that they have, we have as approved medication, at a much lower price and at virtually all the strengths that you want. The transdermal testosterone is now also available in South Africa in pre-approved, and it is pure testosterone. It's in the form of a cream, and you start off by 0.5 milligram, and it is applied to the inside of the thighs once daily for 3 months, and then you can decide whether you need to go up to 1 milligram. Those are 2 stripes on the little applicator, but it's not necessary to go up. Now, who needs testosterone replacement to their regime? It's only the patients who have hypoactive sexual desire disorder. It doesn't really help for anyone else. So what you're trying to do is you're trying to normalize the lowered levels of testosterone in the postmenopausal woman to what it was premenopausally. So you just bring it back to premenopausal levels, and there are very good evidence to show that it is. Do you have to constantly monitor them? Well, it is good to do the total testosterone, not the free androgen index or free testosterone, the total testosterone index. And the reason is not to see whether it's low, because none of the tests that our pathologists do can actually differentiate normal from low levels. The idea to see that it's not high. You don't want to add testosterone to somebody who's got a testosterone-producing tumor. And then after 3 months, you have to check it again, and probably again after 6 to 9 months. And the reason for that is just to see that the patient is not misusing the cream, in that she's giving inappropriate higher dosages, because obviously she can change her own therapy as that goes on. Now, the oral DHEA that we have at the moment in South Africa from the health shops and that, you can just about leave it. It doesn't work, and it just costs a lot of money. Okay, lifestyle modifications. I'm not going to be talking about that. And the botanicals, you know about paroxetine and the other drugs. I'm just going to mention that we now have a non-hormone prescription drug. It's called the neurokinin 3 receptor antagonist. So we've got felonazontin, which is now available in the United States, and it is available in Europe, and we hope that it will soon be available here. So this works on the same pathway as the estrogen, because what happens when estrogen levels go down is that it activates the neurokinin 3 receptor pathway, and that is how the whole process. So you can either bring it down by giving estrogen, which always works. It will reduce the expression of this pathway, or you can block the pathway with a human-made immunoglobulin. So it works very well. I personally think that the main indication for this will be an area where it's not yet been tested, but that's going to be in the patients with breast cancer where estrogen is contraindicated, and they suffer severely from estrogen deprivation, especially on the aromatase inhibitors. So just the last slide is that if you really want to have a very good update on menopausal hormone therapy in 2024, but this was published at the end of 2024, have a look at the white paper from the Menopause Society, and it really addresses everything that I have addressed today, and it gives you a very good idea. And they say the 5 important W's of prescribing MHT is who is the one for hormone therapy, what type and the dosages, when should we start and when should we stop, why is it important, and where can it be assessed. So that's all in this paper, which I think is the latest update on recommendations. Thank you very much for your attention. I think we still have time for some questions.
Absolutely. Thanks, Toby. We do have some questions in the group, in the chat. Thanks so much for a great comprehensive outline of just really and answered a lot of our questions. So Philip Zinn kicks off with firstly saying thanks for a great talk, but he really looking at a comment on whether the evidence of transdermal E2 for fracture risk reduction is equal to the evidence for oral E2. And is there
Okay.
any distinction between patches and gel?
Okay, so the only fracture data that we have is fracture data for CEE plus MPA is used in WHI for just for that. But then we also have fracture data for tibolone. Okay, so there we have fracture data. In terms of all the other estrogens, we only have data that they will prevent bone loss. Now, does transdermal work worse on the bone or better on the bone? It doesn't really matter. Bone is very responsive to estrogen. There was a very good study by Bruce Ettinger in which he used only 15 micrograms. Now, our normal dose, lowest dosage is 25, and even 15 micrograms of the patch did in fact preserve bone density. But be very clear that we don't have fracture data for any of the other dosages.
So in other words, there's no distinction between patches and gel, Toby.
As far as I know, on bone, it is exactly the same.
Okay, thank you. I'll take the second question. Moira Stein, an ideal scenario would be a Mirena and estrogen for a woman with if she does have a uterus, because there's no dilutional effect on the estrogen and less risk related to the breast dementia and CV and cardiovascular disease. Could you comment on that, please? Mirena
Yeah.
plus estrogen.
Certainly, you can certainly use Mirena, especially a patient that had the Mirena in place in the perimenopausal period for bleeding irregularities or menorrhagia. Then you can continue for quite a while because these Mirenas probably will protect the endometrium for about 10 years. It still is, in theory, a good idea for a patient that is recently menopausal. But fitting a Mirena to those patients is not always the easiest thing. If you have to take them to theatre for something else, that's fine. But I just find that the normal menopausal patient is not very happy with the emplacement of a Mirena. But certainly, it may be better in your hands, Moira. It will work, and it has added advantages.
Steve?
Yeah, then Dumisan in Lovers asked, can you use Yasmin for menopausal hormone therapy? I'm not sure understand what the sort of indication would be there, but yeah, maybe you can just give us a general opinion about the use of that sort of concept.
Okay,
Yasmin.
Yasmin, yeah.
so let's just say, can we give an oral contraceptive, combined oral contraceptive, because they're all basically in the same category for postmenopausal symptoms? Well, no, that's unfortunately not a good idea, and it's actually contraindicated because of the high dosages that we use there, which will probably enhance thromboembolic effects. So it is not more effective than estrogen hormone therapy. What is a different question is whether you can use it in the perimenopausal patient. And there I find it to be really helpful because the difference between menopausal hormone therapy and the oral contraception is the oral contraceptive will suppress ovulation. Okay, because it suppresses ovulation, you have no endogenous hormones that you have to battle in the process. So you have a nice clean plate to work on. So I find that for the patient before the age of 51 that presents with vasomotor symptoms in the perimenopause, I put them on the oral contraceptive. Now, which one is probably better there? You would probably go for the generations, it's probably fourth or fifth, but the ones containing natural estrogen, we have two in the market, combined with either Dynogest or combined with Nomac, an normogestrel acetate. The two of them would probably be the best ones to use there. And after the age of 51, I just put them on standard hormone therapy, whatever preparation I think would be best for the patient.
So would that be clearer, Toby?
That's Clara is the one containing Nomac, and so Dynogest, and the one containing Nomac is Zoli.
Yeah. Okay, next one. How important is, Toby, an anonymous person says, how important is a strong family history of breast cancer when deciding to initiate HRT, and is it worth doing an IBIS score? Yes or no?
I think
Suppose
an I think an IBIS score is a good idea in any patient, whether she has a history of breast cancer or not. So breast cancer history in a single, the mom or the grandmother or a sibling is not a contraindication. Okay, but if as soon as you have a more complicated family history, and especially when it's combined with ovarian cancer, then one should not only just do the scoring on one of the models, like the Gale models, the other one which I use, but the patient should be tested for a BRCA1 or 2 gene mutation. But generally speaking, a history of one extra or one case in the family, in other words, a sporadic case, will insignificantly increase the risk of breast cancer.
Okay. Just before we get to Laura Graves's question, just remind us, you very quickly mentioned subtotal hysterectomy. So if a woman's had a subtotal hysterectomy, bottom line is you'd use combined, you wouldn't use estrogen alone. Is that correct?
Well, Peter, there's very, very little work actually done on that.
Yeah.
And you guys from Cape Town that does subtotals give me gray hairs sometimes in deciding whether I should use it or not. I would generally start off with estrogen alone, and just because it's safer, but watch it very carefully on ultrasound and for any bleeding episodes. If they bleed, then I would add a progesterone to it. But generally speaking, it is not necessary to combine it, but there are no hard and fast rules combining that. If you really want to be very safe, well, then use combined therapy. But I think you can get away with single therapy most of the time.
Okay, thanks very much for that.
Yeah, Laura's
Steve?
got the last question. Yeah, a nice clinical scenario of a slim, active 67-year-old on transdermal estrogen and progesterone. She's been on for 12 years and then recently had a reduced exercise tolerance and required a single vessel coronary artery stent. She doesn't want to stop hormone therapy unless absolutely necessary because the quality of life is so much better. And she argues that her mom had coronary vascular disease and demised early on no MHD. So what are your thoughts on that?
So she had a stent, and what was the other thing that she had?
Her mom actually had CVD,
Cardiovascular
cardiovascular disease,
family history.
but
Yeah.
She wants to know-
wasn't on hormones.
She wants to know, would you use Xarelto or not? That's what she's asking,
Well,
Toby.
she want to, can you continue with the MHD as well on this?
Okay, so let's first take Xarelto out of the way because many of the patients are not on a blood thinning preparate. Yes, you can continue. But because these patients will be on a statin or some other form of a protective effect on the coronary arteries. So the effect that you'll have with your menopausal hormone therapy will just be positive, because remember the negative aspect of menopausal hormone therapy is destabilization of plaque. But because the patient is on a statin or other method, then it's fine. If the patient is on Xarelto or other form of blood thinning, then you are okay. You can continue. There's no problem.
Because if they've got a stent, I think most people would argue that they should be on Xarelto. Isn't that right, Toby?
Yeah, I was just referring first to general coronary arterial disease, and with a stent, they're not necessarily on Xarelto. They can also be on other forms of therapy, but you can use that with the continuing hormone therapy. So the only thing that you'll sort of find in the guidelines is that maybe it's better to use transdermal there, and the lowest dosage possible, so about 25 micrograms 2 times per week would be your go-to dosage. And for that reason, you can also use Femigel.
Yeah.
Great.
Okay.
Yeah, Toby, how do you give your testosterone? Sometimes, I mean, I know there are different regimes that people use. How do you actually give your transdermal testosterone? What do you actually use?
Okay, so the what I use now is the preparate. Can I say on your program the
Yes, you can say. Please say.
Testafem?
We usually Testafem, yeah.
Testafem. It's only been around for about a month now, 6 weeks. It's manufactured in Australia by a company called Lawley, and that's the actual product that Susan Davis uses. So we got plenty of literature, and that's been proven. Okay, so it comes in a tube, and then you have a syringe that you attach to the tube. And if you go to the first stripe, that's a 0.5 milligram. Okay, so she has to use that daily, the 0.5 milligram, and she can use it on the inside, or sorry, the outside of her thighs. She can maybe use today on the left side and tomorrow on the right-hand side, or she can spread it amongst the two. So that is the best. That is the method that the Lawley firm actually has it registered for. If you, the rep will probably come around to you, they have a very nice pamphlet insert which you can give the patient that actually shows them exactly how to use that. So as I said, you can do a safety check for testosterone so that you don't give it to a patient that's got high levels. But the actual indication is hypoactive sexual desire disorder. So the patient has to now have low libido, but she didn't have it before when she was premenopausal. There must not be any other things such as that she's the hell in with the husband or whatever. And it should also be causing personal distress. So that's a very important thing. So it is low libido with personal distress, and it actually works very well according to literature. It does not help for anything else. It does not help for bone, it does not help for brain, it doesn't help for heart. So it's a pure indication for hypoactive sexual desire disorder. And you can give it with menopausal hormone therapy. So you can put your patient on Formostin and you can add that, for instance.
Excellent. Thanks so much. And that's available in pharmacies now.
Yeah.
Most pharmacies, we've given them a script. Well, Kirby, thanks so much. It was wonderful talk, wonderful discussions. I'm sorry we didn't have time to talk about laser, but that's for a different different subject. But yeah, we obviously do agree to disagree on that. And yeah, but we'll certainly have time to debate that in some other forum. But thanks so much. But absolutely wonderful talk. We really appreciate your time. And, you know, someone of your caliber and expertise, you know, giving us your time is much appreciated by us. And, you know, as evidenced by the huge number of people who attended. I mean, there were about nearly 180 people.
No, near over 200 people.
Yeah, so we thanks so much.
Great forum.
Yeah,
and
thanks so much. Yes.
Thanks to Abbott and also thanks to Chris.
Yes, thanks to Chris. And we are. So enjoy your evening now. See, it's getting quite dark in Stellenbosch. It's still a bit light here in Cape Town. But
And also,
yeah, great. We look forward to having you also at FIGO, which is in October. It's wonderful that you can be there with us, and you're a great supporter of our forum. So once again, thank you very, very much. And it'd be quite wrong of me to say goodnight without thanking Steve for the use of his mini bar. Steve, thank you. And we look forward to our presentations next Thursday on the same forum. Safe home, Turby. All the very best. And thanks to Steve and to Kirsten Piller and Devon Sprague again for being with us over here.
Thanks to you as well, Pete. Thanks so much.
good.
Great. Thank you very much.
Thank you very much.
Bye,
Good
everybody.
evening.
Bye. Bye.